Forest plots, do they mean something to you? Aeroplane graphs, some people call them. So this is a way of averaging good studies that have been done. Some may not show a statistical difference by themselves, but maybe if you pool all the data, there's a more powerful statistical model there. And interestingly, you can also look at whether the effect is sort of heterogeneous. Is it, you know, inconsistent? So if it falls on one side of this line, 0, then that's telling you that the effect is really consistent. And that's what you find here with these studies. So these are studies that met the criteria. This is in the Cochrane Library, which is, you know, the best you can get, basically, in terms of clinical evidence. And you can see that compared to the best practice ADA diet, a low GI diet produces another an incremental fall in HbA1c equivalent to 0.5 percentage point. And that's clinically important. All right. Perhaps one of the reasons why low GI diets improve HbA1c is because they improve insulin sensitivity. So this is 12 type 2 subjects, 12-week crossover study, and they maintained their weight throughout. So it's not about weight loss, and weight loss we know already improves insulin sensitivity. And this is the best gold standard method of measuring insulin sensitivity. It's the euglycemic hyperinsulinemic clamp. And so this tells you that on a low GI diet, people can deal with a glucose load or a carbohydrate challenge much more easily. They can metabolically deal with it much more easily. We've just finished this study and published it. It's in this month's issue of American Journal of Clinical Nutrition. It was a really hard study to carry out because women with polycystic ovarian syndrome are a really hard group to study. They find it difficult to lose weight, much more difficult than the average person, much more difficult than even people with type 2 diabetes. And they had to lose 7% of their body weight or be trying for at least 12 months to lose that weight before they finished our study. And a lot of them never got to 7% on either diet. But by the 12-month point, we did the final tests. And this is the change of insulin sensitivity. The improvement in insulin sensitivity was higher in the low GI diet than the high fiber diet, the conventional healthy diet. And that's even though they lost an equal amount of weight. So that's what our endpoint was. They had to lose a certain amount of weight, and then we did the final tests. So weight loss differences don't explain that difference in insulin sensitivity. So, and this slide to me is one of the best reasons why we should be recommending a low glycemic index diet for everyone. Because this is a meta-analysis, it's published, a meta-analysis of all the studies that have been done looking at the correlation between risk of type 2 diabetes in prospective studies and the glycemic index of their diet. They all favour the low GI diet. We selected only the studies that had validated their carbohydrate content. They'd validated and showed that their method of measuring carbohydrate intake was the same by 2 different dietary history methods. So when you do it that way, it's really consistent. Are you used to looking at data like this in quintiles and relative risk? Yes? So when we look at quintiles, we're dividing a population up into 5 groups. And in this case, we're dividing them up into 5 groups according to their glycemic load of their diet. So we've analysed their diet at baseline. We've divided them up into 5 groups. This group has the lowest glycemic load. This group, quintile 5, has the highest glycemic load. And this is their relative risk for gestational diabetes. So this is the Harvard Nurses' Health Study. It looks at the 13,000 women that got pregnant during the study over 8 years of follow-up, and it's looking at who had gestational diabetes and who didn't. Okay? And what you see is that in quintile 5 of glycemic load, there were 60% more cases of GDM. And that difference was significant after multivariate analysis. So adjusting for differences in fibre content or differences in family history or energy or BMI, and it was still statistically significant. And it, interestingly, fat, type of fat, carbohydrate content, sugar content, none of those predicted who got gestational diabetes. All right, low GI diets also reduce the need for insulin in women who have a diagnosis of gestational diabetes. I did this study with an endocrinologist who is one of Australia's, one of the world's, for that matter, considered one of the most important, renowned experts on gestational diabetes. His name's Bob Moses, and he's on the ADA recommendations, guidelines and things, and he's sub-editor of Diabetes Care. And you can see that they were twice as likely to need insulin if they had during the last 10 weeks of pregnancy if they were following a conventional high fibre diet, twice as likely. And in a group of normal pregnant women, 62 healthy women were assigned to low or high GI diets at the 16th week, by the 16th week of pregnancy. So they followed either the conventional high fibre diet or they followed a low GI diet instructed by dietitians. They saw the dietitian 5 times over the course of the second and third trimester of pregnancy. And at the end, we looked at the number of large and small babies in each group. And this result absolutely stunned us. There are 10 times more large babies in the conventional high fibre group compared to the low GI groups. No difference in small babies, but a 10-fold difference in the number of babies above the 90th percentile. So that's roughly a baby who's weighed 4 kilograms at birth. Do you know what your birth weights are? You know your birth weights? Babies are getting bigger and bigger, in case you didn't know, and that's partly because women are going into pregnancy at a higher BMI and they're gaining more weight during pregnancy. But one of the most established facts in pregnancy is that the mother's blood glucose level is directly correlated with the baby's weight. That's why they treat women with gestational diabetes so carefully, because the high birth weight baby is a risk factor for a very unpleasant delivery, emergency cesareans, shoulder dystocia, preeclampsia, you name it. Also, the big baby above 4 kilograms has a much higher risk of childhood obesity. So in my books, my hunch is that our childhood obesity epidemic has a great deal to do with the fact that mothers' blood glucose levels are getting higher and higher. Partly to do with their weight, but partly to do with the fact that our diet is so high GI. All right, so coming back to some more epidemiology, this is the Nurses Health Study, 20 years of follow-up, 82,000 women. It doesn't get much better than this. And they divided the women, the population, up into deciles of glycemic load. So deciles is dividing them up into groups of 10 groups. So this group here has the lowest glycemic load, this group here has the highest glycemic load, and then they look at the number of cases of cardiovascular disease in each of those 10 groups. Okay, and in this case, the cardiovascular disease was actually heart attack, all right? Heart attack. And you've got an almost 2-fold risk of having a heart attack if you're in the highest decile of glycemic load. And that's after highly significant, and it's more significant than fat or type of fat or sugar or starch. It's glycemic load. And what I wanted you to notice, I said before that I think, glycemic load is not as important as glycemic index. I think glycemic index is